meetings before, so please bear with me. Uh, I may make some mistakes. Hopefully, I won't. But okay, let me introduce our speaker tonight. Dr. Bilal is originally from Pakistan, where he earned his medical degree. He then worked as a research associate in neurology at the State University of New York in Buffalo and completed his internship and residency at the University of Louisville School of Medicine. He also has completed a fellowship in clinical neurophysiology and electroencephalogram at the University of Pittsburgh Medical Center in Pennsylvania. Dr. Bilal is board certified by the American Board of Psychiatry and Neurology, as well as by the American Board of Clinical Neurophysiology in the specialty of neurology with subspecialty certification in epilepsy, critical care EEG monitoring, and advanced central clinical neurophysiology. On a professional level, Dr. Bilal serves our area through his work as epileptologist in Owensboro Health Regional Hospital, where he recently oversaw the development of the first epilepsy monitoring unit in our region. On a more personal level, I recently ran across an article published in the British Medical Journal that listed the most important qualities of a good doctor. They are compassion, understanding, empathy, honesty, competence, commitment, humanity, courage, respect, and optimism. As a person with epilepsy myself and as a very satisfied patient of Dr. Bilal's, I can say with certainty that he possesses each and every quality of not just a good doctor, but a great doctor. I sincerely appreciate his support of the Epilepsy Foundation of Kentuckiana, Owensboro Health, and each and every one of his patients. So Dr. Bilal, if you will unmute yourself, the floor is yours.
All right, can you see my screen?
Yes.
All right. Thank you everyone for joining me in this educational talk. I really appreciate your time. I am extremely thankful to Mr. Petit for giving me this opportunity to talk. And I feel honored to educate community on base of Epilepsy Foundation. So, so today I will discuss medical and surgical treatment options for epilepsy. So when I was making this presentation, I realized that the target audience is diverse, and I'll try to use simple words and simple language so that everyone can understand what we are talking about. I'll try not to use medical terminologies, but if I do use it, I'll try to explain. So without any further ado, let's get started. I have nothing to disclose. So here is the outline of my talk. So although the topic of this discussion is medical and surgical treatment options, I feel obligated to educate the community about the seizure and epilepsy, because seizure does not always mean epilepsy. And there's a lot of misunderstanding when it comes to the patient when they mistakenly think that they have epilepsy. So I will briefly talk about seizure types, statistics. I'll talk about some events that look like seizure, but they are not. I'll also show you some videos of patients with different kind of seizures. And of course, I'll talk about medical management, medical devices, and surgical treatment options. I also put a small discussion on COVID-19 and epilepsy. So I was seeing one patient today this morning, and he asked me a lot of good questions about COVID-19 and epilepsy. So I realized that this is a good platform to address those issues as well. So as we know that human brain is made up of billions of cells called neurons. So neurons are the main cells which represent structure and function of the central nervous system. So they talk to each other and they communicate each other using chemical and electrical signals. It's very important to have a good flow of electrical and chemical signals between these cells, because if any excess of this signal can cause a lot of problems such as seizure. An average human brain has approximately 86 billion neurons. So there's a lot of neurons talking to each other in brain. So any disturbance in these signals, whether it's an excess of signal or under signal, can give a lot of problems. So as we know that seizure is a sudden uncontrolled electrical and chemical disturbance in the brain. It can cause changes in your behavior, movements, or feelings, and in the level of consciousness, depending on the area of the brain involved. As in medical terminology, we call it excessive hypersynchronous cortical neuronal activity, which basically means the same as I described above. It's very important to realize that seizure is a symptom, it's not a disease. It's very important to know this fact. It's just like a fever. When someone has a fever, so we try to figure out the underlying reason for fever. You not only treat fever, you also try to find out whether the patient has infection or patient has inflammation going on in the body, because that's the root cause of the problem. So the similar is seizure. Seizure is a symptom, it's not a disease. So when anyone has a seizure, it's very important to know whether they have epilepsy or not, because seizure can also happen from number of different reasons. If someone is sick from infection, say for example from infection, or if someone has any electrolyte abnormality like low glucose or very high glucose, or disturbance in the sodium or calcium, that can also give rise to seizure. That does not mean that patient has epilepsy. It's just because the patient has underlying provoking factor to have a seizure. So it's very important to realize that whenever anyone has a seizure, every effort should be made to know whether the patient has epilepsy or not. So now it takes into account, so what is epilepsy? So the epilepsy is defined as two or more unprovoked seizures more than 24 hours apart. So it's very important to realize that these should be unprovoked. They should not have any underlying provoking factor. The provoking factor could be disturbance in the glucose, sodium, and infection, and a number of other things as well. Or one unprovoked seizure and a probability of having a second seizure similar to general recurrence risk of 60% over next 10 years. So this take into account some other circumstantial evidence like in the form of EEG or MRI or family history. So you take into account after one unprovoked seizure, whether they have a probability of having further seizures or not, or a diagnosis of epilepsy syndrome. So epilepsy syndrome, say for example, a juvenile myoclonic epilepsy. If someone has juvenile myoclonic epilepsy or Lennox-Gastaut syndrome, so then they have epilepsy. So it's very important to realize what epilepsy is as opposed to seizure, because seizure does not always mean that someone has epilepsy, whereas the patient with epilepsy presents with recurrent unprovoked seizures. So I'll briefly talk about different seizure types. So as you can see in this diagram, that on the left side, seizure can be focal onset, which means that the seizure originates from one part of the brain. And they are further classified into aware or impaired awareness. Aware means the patient is aware during the seizure, whereas impaired awareness would mean that patient loses awareness of the surrounding when the seizure is happening. It is further subclassified as motor onset or non-motor. Motor means when the patient is having any movement like shaking or jerking. Non-motor would mean any non-motor symptoms like tingling, numbness, or visual symptoms like hallucination or flashy lights before the eyes. It's important to realize that the focal onset seizure can also progress to what we call as a grand mal seizure or bilateral tonic-clonic. The second biggest classification types is generalized onset, where you have seizure originating from every part of the brain at the same time, as opposed to focal onset, which originates from one part of the brain. And these are again of two types, motor and non-motor. Motor means you have a movement with the seizure, like tonic means a stiffening phase, and clonic means convulsions. So whenever the patient is having a seizure, they will stiffen up and they will have convulsive activity. They can be non-motors, for instance, like in patient with absence seizures or absence epilepsy, they have non-motor symptoms because they don't do anything. They're just staring off in the space. They are just frozen in time. And sometimes we don't know the onset, and we call them as unknown onset. And again, it could be same motor and non-motor, and sometimes it's unclassified. We don't know. So when anyone suffers from seizure, it is important to know whether patient has epilepsy or not. Having a diagnosis of seizure is not enough. Every effort should be made to see whether the patient has epilepsy or not. So when it is determined that someone has epilepsy, it is equally important to know the type of epilepsy if possible. Having a diagnosis of epilepsy is not enough. Sometimes it's not possible to know what kind of epilepsy the patient has, because sometimes the patient may have a focal epilepsy, but due to the rapid spread of electrical activity, it may look generalized. So it's always very important to further dig out, what kind of epilepsy the patient has, because it's important, because the treatment options are little bit different if you have focal epilepsy versus generalized epilepsy, if we talk about surgical options, for instance. So I'll talk about statistics briefly. So about 1.2% of the US population has active epilepsy, which is about 3.4 million people with epilepsy nationwide. This includes 3 million adults and approximately 500,000 children. Approximately 8 to 10% of the population will experience a seizure during their lifetime. Only about 2 to 3% of the patients go on to develop epilepsy. Incidence rate for epilepsy is about 44 per 100,000 in the US. Epilepsy poses a substantial and societal burden that require heightened public action. In Kentucky and southern Indiana alone, more than 90,000 people have epilepsy. Epilepsy is the third most common neurological disorder in US after Alzheimer's, dementia, and stroke. There is no cure for epilepsy, but medication, implantable devices, and surgical options can help control seizures. So I'll talk about some events that look like seizure, but they are not. So the most common misdiagnosis of epilepsy is psychogenic non-epileptic spells or seizures. They look exactly like a seizure, and they happen as a result of psychological distress. So sometimes the body responds in the form of a spell that look like a seizure, and that's how it's mistaken sometimes as having epilepsy. That's the most common misdiagnosis of epilepsy that we see in our practice. Sometimes syncope can look like a seizure. Syncope means a passing out spell. So it also looks like a seizure because your brain needs constant blood supply and oxygen to function. When there is interruption of the blood flow to the brain, then the brain can get irritated, and it can result in a variety of symptoms like passing out, or sometimes they can have jerking of the arms as well, because the brain cells don't like lack of oxygen and blood. Another important mimic that look like seizure is a migraine headache. Sometimes migraine can present with variety of neurological symptoms, such as they can have visual aura, they can see some flashes in their visual field, they can have tingling or numbness on the part of the body. They can be confused at times with the migraine headache, and that can also look like a seizure. Another important mimic is transient ischemic attack. So these are the attacks that look like stroke, but they reverses on their own. Sometimes these symptoms can also have the symptoms that look like a seizure. So it's very important to differentiate these ischemic attacks. Sometimes certain movement disorder, like if someone has tremors in their arms or in their legs, or the tremor in their neck, that can also be mistaken as a seizure when they are not. Sometimes sleep disorders, in the REM sleep, they can have abnormal movement or abnormal behavior during the sleep, and that can also mimic like a seizure. So it's very important to differentiate those disorders as well. Sometimes hallucination, which could be from number of different reasons, which could be from the medications or medical condition, also look like a seizure. So it's very important whenever a patient sees a doctor or neurologist, it's very important to take into account different medical conditions that may look like a seizure. As we know that psychogenic is the most common misdiagnosis of epilepsy. These are involuntary manifestation of a psychological distress. And again, the body is reacting to stress in a way that looks like a seizure. It's not in the voluntary control of a person. So it's very important to differentiate them, because these are the spells that will not get benefit from any seizure medication. As I said, anti-seizure medication have no role in treating non-epileptic spells or seizures. So I'll show you some videos of different kind of seizures, because I want to educate community about how different seizures look like. Seizure does not always mean that you are having a shaking or stiffening spell, or you are frozen in time, or you are having a staring of spell. Sometimes seizure can manifest in so many different ways, and sometimes it's so confusing to know whether they have seizure or not. So all the videos in this presentation, I took it, some of the video I took it from the medical literature and are available online. So there are only 2 videos that I obtained from our own patients after getting appropriate patient consent to be used for educational purposes only. I hope the videos work. So before I show you first video, so I want to share this video, case number 1. So this is a patient that I saw in my hospital, I would say about a year ago. A 53-year-old female, she was diagnosed with seizure disorder about 5 years ago. And she came to the emergency department with a seizure-like spell. There was no clear description of the spells. Patient will say, I don't know what happens, I just pass out, and then after a few minutes or so, I'll get back to normal self. Patient had brother and sister with seizures. Patient has some cognitive slowing and depression. She had multiple ER visits for seizures. At one point, she passed out during seizure and CPR was performed by family. She has tried several different seizure medication in the past, which includes Keppra, Topamax, and she was recently started on brivaracetam. So she came to the emergency department, and I told the team to get admitted to the hospital so we can do a continuous EEG on her. So I want the audience to notice, to look at the patient. So what's happening with the patient? I hope the video works. Yeah, it's working. So as we noted that she had a spell where she was having a movement of her bilateral of both arms, and she was seen to have her head shaking from side to side as well. And so she will have several of these spells every day, and sometimes these spells will last for 15 to 20 minutes, and then she will sometimes pass out, and the family will start doing CPR on her. So that poor lady, so we evaluated her in the hospital so as to get to the bottom of this, and we realized that these were non-epileptic in nature. When I spoke to the patient about it, and she became so relieved, and the family also got so relieved, because they will start doing CPR on her, and she was on several different seizure medication before coming to us, and so we determined that they look like seizure, but these are not epileptic seizures, and these are in response to psychological stress that your body is reacting in that way. So we told her appropriate treatment plan, and she became much better. So it's very important to understand whether the seizure the patient is complaining about is epileptic or not. So this case number 2. So I want to show you an epileptic seizure. So this is I took it from the medical literature available online. So this is in the setting of epilepsy unit at some of the hospital, And so sometimes patients get admitted to the hospital to get evaluated about the epilepsy type or surgical workup. So let's see how his seizure look like, and this is how the real seizure look like.
How you doing there, Billy? Okay. Can you remember 4 blue balls? You want to give Jessica 4 blue balls? Okay. Give me your hand. Can you remember anything? Here you go. Give me your hand. Okay. There you go. Okay, nice. I'm going to get some Madeline out there. Well, yeah, but it was only 90 seconds last time. The doctor's here. 90 seconds is longer than that. Once the thing was only 90 seconds. What you were seeing was supposed to fix them. And I'm going to get over here with the shoulder. Billy, we're trying to get get him on the side, bite his tongue. I'm not gonna move. What, you don't use it anymore, do you? I don't know, I thought maybe get him on his side here. There's 2 milligrams right now. 2 milligrams now. I keep this shoulder stabilized here. I'm gonna keep it stabilized. Yeah, he is.
As you noted that patient pressed the event button because patient felt the seizure was coming. And at the start of seizure, you noticed that he was having some mouth movement. He was having some, twitching, and he was doing a lot of swallowing movement. And then he stopped responding to the technician command. And then slowly he started having a twitching over his face, and then he started convulsing. He started stiffening out. So this is how a seizure looks like. It seems to me the patients had a focal seizure which rapidly progressed and became widespread. So this is one of the presentation that the seizure can present with, and you can also notice in this patient is that his left arm was on a sling, so which gives me an impression probably he had a shoulder dislocation in the past, probably from a seizure. We sometimes see shoulder dislocation after they have a seizure. So let's look at case number 3. So this is the patient, very interesting patient interesting patient that I saw during my fellowship training. So his girlfriend told us that the patient will have several spells during night where patient will be turning around in the bed, and then he will be confused. He will be very irritated, and so initially she thought that this could be a nightmare or night terror, and then they started happening again and again, and so we decided to have him bring to the hospital and do some monitoring. So just look at the video of what patient does actually.
Okay, well, okay.
So as you see that, he was having several of these spells every night, and these were very typical for him. So what he will do is that he will turn around in the bed, and then he will wake up all of a sudden, and then he will start looking around, and he will be confused. And based on our literature, we know that turning of the body the behavior that he's having, which was repetitive in nature, could represent a seizure and epilepsy. So in fact, patient did have epilepsy, which was located in the frontal lobe deep inside. So seizure can also present with such a diverse manifestation. So it's important to know, and it's important to take home message when any patient is having a spell that arises out of sleep without any explanation. It's important to go and see a doctor and ideally see a neurologist. So this is a very interesting case. Let's see what happens over here. So what will happen in her seizure is that whenever she will have a seizure, she will have a sad face, which we call as a pouting or ictal pouting. So that was all her seizure. So and who knew that that would be a seizure symptom as well. So if any symptoms keep on happening again and again without any explanation, then a seizure should be considered and patient should get appropriate workup done.
I don't remember if it's.
So this is another interesting case that was published in Neurology Journal. So this young guy, so he will have a variety of complex movement of his arms and legs, and so patient saw multiple other doctors for the treatment of this. So it was finally found that patient was actually having a seizure during those spells, and that tells us that how diverse the seizure manifestation could be.
This one comes from. Yes. Look at me. I found the one that I think it was.
So as you saw that, seizure can present with so many variety of symptoms. Seizure come in very different flavors, and seizure does not always mean that the patient is shaking or stiffening up or staring off in the space or being frozen in time. Seizure can also happen with some very atypical symptoms depending on the part of the brain involved. So the key is if the patient is having those symptoms again and again, it's very stereotypical or repetitive in nature, then it's very important to see a neurologist and preferably epileptologist to further sort that out. So I'll talk about the medical management of the epilepsy. So whenever a patient has, once we determine that the patient has epilepsy, now it's time to start a seizure medication. So there are a lot of factors that influence our decision to start a seizure medication. So as I mentioned previously as well, it's important to know what is the classification of epilepsy, what is the seizure type, and what is this classification, whether it's a focal seizure, whether it's a generalized seizure, whether it's an epilepsy syndrome, whether it's like autoimmune epilepsy, and so on. So these are very important decisions to take into account when you start someone on seizure medication. So, and again, epilepsy syndrome like juvenile myoclonic epilepsy, there is Dravet syndrome, Lennox-Gastaut syndrome, a lot of symptoms where starting certain seizure medication will be detrimental. So it's very important to take into account all those things. You have to look into tolerability profile. You have to look into comorbidities. For instance, if the patient has a kidney stone, you will rather avoid Topamax because that can also give rise to the kidney stones. If the patient has a mood or anger issues, you will avoid certain medications that can further aggravate that situation. So there are a lot of comorbidities that you have to take into account when you start the seizure medication. Of course, then you have to look at the metabolic status as well. For instance, if the patient has a liver problem, so you will not use a medication which are extensively metabolized through the liver. Also, you will also take into account the kidney status, and you will try to avoid the medication that have predominantly renal excretion. So for example, gabapentin or Keppra. Then you also look into drug interactions because a patient may have other drugs that they are taking, and it's not sometimes easy to start a severe medication without knowing whether there will be any interaction or not. You also take into account drug formulation because sometimes patient cannot take pills or capsule, or they prefer oral solution or prefer powder or something. Then you also need to take into account pregnancy and contraception because we know that serial medication are not safer in pregnancy. I'll talk about later as well about it as well. So, and also we have to take into account contraception because there's certain medication that decreases the efficacy of the medications. And of course, it's very important factor which is often neglected is a cost. So we have to make sure that the patient is getting that medication because if it's too costly and the patient cannot pay it, then there's no point, and then we are not achieving our goal. Also, we have to think about the availability of the medication because certain regions may not have all the CA medication available, readily available. So currently there are about 26 FDA approved anti-seizure medication in the US. The most recent medication approved by the US FDA is cenobamate, which came in late 2019. I won't go through all 26 medication because it's not possible. It will be the purpose of this educational session. So, but I will talk about some medications which are very popular. As you can see in this graph, starting from 1900 till 1978, we had only 5 seizure medication which were approved to be treated for seizures, like phenobarbital, phenytoin, ethosuximide or zerontin, Depakote, carbamazepine. Then between 1978 and 1993, there was no new seizure medication. For about 15 years, there was no new seizure medication. Then in 1993, felbamate came, and then you see a sudden influx of all the new seizure medications. We are all familiar with the older medications like phenytoin, dilantin, Depakote, carbamazepine. So the purpose of showing this slide is that there are so much other options available as well if someone fails the traditional medications. The most recent medication that was added to the list was cenobamate, which was added in 2019, in November 2019. But I will talk about some of the medications. So phenytoin, we all know it commonly as dilantin, and it has been used in use since 1938. So it follows what we call as nonlinear kinetics. What does that mean is that traditionally, if you increase the dose of medication, the level of that drug in the blood goes in a linear fashion. You increase the dose, the level of the medication goes up. You increase the dose, it goes up more. But in case of phenytoin, there comes a point when increasing a little bit of dose will result in exponential increase in the level of that drug in the blood. So it's very important and careful to take into account that information because that can easily result in toxicity. So that's the only medication in our group which has nonlinear kinetics. The common side effect of this medication are headache, nausea, incoordination, and drowsiness. And long-term effect includes gingival hyperplasia, which means there is a swelling of the gum or gum hypertrophy. There's a hirsutism, hair on the face, cerebellar atrophy, which is basically a part of the brain on the back, which is responsible for the coordination and fine motor task. Um, these are the long-term side effect of phenytoin. And phenytoin is not safe in pregnancy. It can cause birth defect. And the most notable birth defect is what we call as fetal pterygium syndrome, where the baby is born with coarse facial features. They can have some skeletal abnormalities as well. One of the other old medication is carbamazepine. It's also known as tegretol or carbetrol, depending on what formulation you use. It was FDA approved in 1968. It is extensively metabolized by liver enzymes. Common side effect includes nausea, GI discomfort, dizziness, incoordination, drowsiness, leukopenia, which means a decrease in the cell count of leukocytes. Then it can also result in low sodium. Um, in Asian population, there is a risk of having a Stevens-Johnson syndrome. So you always check for a particular allele. You do a genetic testing in those population when you are about to start this medication on them. And it can also cause birth defect, which most notable is the neural tube defects like spina bifida. Then we talk about valproic acid. It's also known as Depakote. It was FDA approved in 1978. It's extensively metabolized by liver enzymes. The common side effect includes gastric irritation, nausea, vomiting, tremors, weight gain, hair loss, thrombocytopenia, which means that decrease in the platelet count. So it can cause confusion secondary to elevation of ammonia. It's toxic to liver, so it's hepatotoxic. It's also not safer in pregnancy because it causes the birth defect, more specifically the neural tube defects. So you take into account the side effect profile when you start someone on the medication, because if they have liver issue, you would rather not start this medication. Or in a young female, you will not start this medication because of the risk of birth defects. Lamotrigine is also very commonly used. It's favored by many neurologists. It's also known as Lamictal. It was FDA approved in 1995. It is extensively metabolized in liver. Its efficacy is decreased with contraceptive pills. And it's important to talk to the patient about whether they are taking any contraception, especially specifically the pills. Um, the common adverse effect include blurry vision, headache, double vision, tremors, rash. It can cause what we call as a Stevens-Johnson syndrome, which happens in 1 in 4,000. So it's very important for us to start this medication slowly and go up on weekly increments. So it's always started in a slow increments to achieve the target dose so as to prevent the risk of Stevens-Johnson syndrome. Studies have found no increased rate of birth defects, so it's a preferred choice in pregnancy. And it's mostly favored in patients who want to get pregnant. But one thing to realize is that, when the patient is pregnant, the therapeutic level of the medicine is sometimes difficult to achieve. So you have to have frequent visits to the doctor so as to make sure that you are getting enough medication. Another medication is Keppra or levetiracetam. So it was approved in 1999. It's a very popular medication among the physicians, whether it be primary care physicians or neurologists or epileptologists. It does not have any liver metabolism. Common adverse effect includes somnolence, dizziness, irritation, hostility, mood issues, psychosis. It has a relatively lower rate of birth defects, so it's a preferred choice in pregnancy. So again, so you have to tailor these medication depending on the patient's profile. If they have any mood issues or psychosis or depression, you will try to use other medications. Regardless, Keppra is a very good medication. You achieve the therapeutic range in no time. Cenobamate, so this is one of the medication which came in the market very recently, also known as Xcopri. It was FDA approved in 2019. It's extensively metabolized in the liver, and the common adverse effects include drowsiness, dizziness, as you will see with every every severe medication. It can give you headache and double vision. It can cause shortening of the QT interval, which is a conduction pathway in the heart. If someone has a heart issues, they should better tell the epileptologist that they have issues with the heart so that they take into account before they start you on cenobamate. It can also lead to what we call as DRESS syndrome. So DRESS is an autoimmune syndrome which can cause a rash. It can cause decrease in the blood count. It can cause a lot of other issues related to that. It also has a psychiatric manifestation, psychiatric side effect, like it causes suicidal thoughts. And so for cenobamate, there's not enough data on birth defects. So since it's one of the newer medication that recently got approved. So that's another interesting topic that sometimes we get asked in the clinic about the using of medical marijuana or CBD. So we have to realize that the only FDA-approved compound from the marijuana is Epidiolex, which is a pharmacologically regulated substance and has FDA-approved content of CBD to tetrahydrocannabidiol ratio. So THC component should be less than 0.3%. So the commercially available CBD oil may not have a desired ratio of CBD to THC, and hence it is somewhat challenging to prescribe. The reason is because THC is problematic. It can give you a variety of negative symptoms like a dependence and a feeling of euphoria, elevation. So THC is a problematic component in the commercially available CBD oil. So the only FDA-approved drug is known as Epidiolex. So Epidiolex has been approved by FDA to be used in childhood refractory epilepsy syndrome, such as Lennox-Gastaut syndrome, Dravet syndrome. However, its use has also been increasingly in other refractory epilepsies, such as tuberous sclerosis complex and infantile spasm. So there are some rescue medications that can be used when the patient is having repetitive seizures. These are different from the daily seizure medication, which is taken every single day to prevent seizures. Rescue medication are only taken if the patient is having seizure clusters and just to prevent seizure from happening again and again. So rescue medication are typically used for seizure clusters, often called acute repetitive seizures, or when the seizures are more frequent, longer, or more severe. Rescue treatments are only taken as needed basis to try and prevent severe emergency from occurring. The US Food and Drug Administration has approved several medications for out-of-hospital use for the treatment of acute repetitive seizures or clusters. These include Diastat, diazepam rectal gel. They include Nasilam, which is a midazolam nasal spray. They also include Veltoco, which is a diazepam nasal spray. As we know that the Diastat may not be appropriate in every age group, so now we have an inhaler medication as well, which is FDA approved and can be used as a rescue medication. So this takes us to drug-resistant epilepsy. So we know that approximately 30% of all epilepsies, they are resistant to drug. They don't respond to combination of drug treatment. So that's why we call as drug-resistant epilepsies. No matter how many medication you put them on, they will still continue to have seizures. Drug-resistant epilepsy is defined as failure to achieve seizure freedom after adequate trials of two appropriately chosen anti-seizure drugs at appropriate dose. So sometimes we see a lot of patients who are on 2 medication, 3 medication, 4 medication, or even 5 medication, and still they are having seizure. And whenever there is a lot of medications the patient is taking, there's a risk of drug interaction. And that's always problematic because that can sometimes influence the level of other drugs. So it's very important to sometimes we see in our clinic that the patient is on several different medication, but none of them are appropriately dosed. It is very important to have certain medication reach their certain dosage range before we call them as a failure. So if any medication is not appropriately dosed, then that's not a failure of medication. So that takes us to our next topic, which is our medical devices. So which is a non-pharmacological treatment, because when the medication are not helping, then you have to think out of the box, and then comes the medical devices. So one of the common medical device that we use for the prevention of seizure is vagal nerve stimulator. So as you can see on the animation on the right side, so it's just like a pacemaker. So you have to put that battery under the skin on the chest, and then the leads come out of it and they get wrapped around the vagus nerve. And the idea is that this generator or battery, it sends continuous impulses of electricity and it stimulates the vagus nerve. And the idea is that this vagal nerve stimulation breaks the seizure cycle, or through the modification of thalamocortical projections and so on. The exact mechanism is still not known, but this is what is believed, that it causes, it alters the brain seizure network. So as we know that it's also known as a pacemaker of the brain. It's a stimulator device implanted under the skin in the chest. A wire from the device is wrapped around the vagus nerve. A person with a VNS device is not usually aware it's operating. So it's continuously operating throughout based on the settings that we as a physician set it to. VNS therapy has been approved by FDA as an add-on therapy for adults and children 4 years and older. It is approved to treat focal and partial seizures that do not respond to seizure medication. So if someone has a bad epilepsy, and patient should be evaluated by an epileptologist to come with a treatment plan where the patient needs further investigation to see whether the patient is a candidate for any kind of devices or surgical resection. So there was a paper published, which looked into the efficacy of the VNS. A review of 65 people who had VNS for 10 years or more showed improvement in seizure control over time. Seizures decreased by 36% after 6 months, 58% after 4 years, and 75% by 10 years after the VNS was placed. Recovery time after seizure may be shorter for some people. 8 out of 10 people reported an improved quality of life. About 6 out of 10 reported less worry about seizures and improved alertness. Half of the people reported that their seizures were less severe. So this is some promising data that came out from the VNS study. Another device that sometimes is used to prevent seizure is the responsive neurostimulation. So it's also a very smart device that looks like a battery, and it has two leads that come out of it. So these leads go into the area of interest in the brain. They sit there, they record the electrical activity of the brain, and they give stimulus in response to unusual activity that they record. So that's why it's a very smart device, because it detects the abnormal pattern by recording them, and then it provides stimulus on demand if there is to prevent any seizure from progressing. So it's similar to heart pacemaker. It can monitor brain waves, then respond to activity that is different. And people cannot feel the stimulation when it's programmed. It doesn't cause pain or any unusual feeling. RNS therapy has shown to reduce seizures and improve quality of life in most people who have used it. So this is a procedure which is done by neurosurgeons. So they will make a hole in the skull. Skull is a very thick bone. It has two layers, and this battery sits in between the layers. And usually the patients, they don't feel anything. They don't feel this generator in their skull at all. And then based on the area of interest, the leads are implanted in that area. Say, for example, if the patient has epilepsy coming from two different parts of the brain, so they will put the leads over there. So try to, provide stimulus on demand. So this is different from VNS, because VNS provides continuous train of stimulus or electricity, whereas responsive neurostimulation gives you an extra stimulus in response to something abnormal that may happen in the brain. At the same time, the RNS, is designed to work in three ways. It monitors brain waves at the seizure focus all the time, even during sleep. It detects unusual electrical activity that can lead to a seizure. It responds quickly within a milliseconds to seizure activity by giving a small burst or pulses of stimulation. This goal is to help brain waves return to the normal even before it could turn into a seizure. As you can see on the diagram on the bottom, as you can see, this generator device is put in the hole created in the skull, and then the skin of the scalp is resutured, and then it lays there, and the patient is not even aware of it. So long-term treatments with responsive neurostimulation in adults with refractory partial seizures. So they looked into the data, and they found that 230 patients with RNS system were followed over time in a controlled trial. The average decrease in the seizure was 44% after 1 year, 53% at 2 years, and up to 66% after 3 to 6 years of using RNS. So that's a promising data, especially in patients who failed multiple medical management. So regarding the quality of life, a study of 191 people with RNS system found improvement in the quality of life aside from the seizure control. These included physical health, cognitive functioning, emotional health or mood, less worry about seizures, overall quality of life. It's important to note that the goal should not only be the seizure reduction. The quality of life is also very important. So it doesn't make any sense if the patient is on tons of different seizure medication, but they at the expense of not being able to function. Because when there is so many medication, the patient may be drowsy, may not be able to work. So that's not the quality of life. So the quality of life has to be taken into account when we manage patient with seizures or epilepsy. So deep brain stimulation is one of the newer devices which was approved, I guess, in 2018 for the treatment of partial epilepsy. It's a kind of neuromodulation. It requires a neurosurgeon to place electrodes in the specific area of the brain called the thalamus. It's the deeper part of the brain. It's also known as brain within a brain. It's a very important organ in the brain itself. The electrodes transmit constant or intermittent stimulation to modulate the excitability of certain circuits of the brain, which in turn can reduce the seizure frequency. DBS is approved for use in adults with seizures that have not responded to medication and who are not candidate for any other type of epilepsy surgery. Again, this also works in the same principle as of VNS because it also sends a continuous train of impulses or intermittent impulses. So it's not in response to seizure. It is also continuous as just like a VNS. So there was a review in the literature on the deep brain stimulation and drug-resistant epilepsy. So about half of the people who have DBS have less seizures with this treatment. For others, DBS therapy may reduce seizure severity. The positive effect of DBS therapy may not be seen right away. As with other neuromodulation, it can take time for DBS therapy to show its full benefit. Also, many patients have increased improvement of their seizures over time. DBS is always used together with seizure medication, like other devices used to treat epilepsy. If seizure controls improve with DBS, seizure medicines may be lowered to lessen the side effects. So that's the main goal of these devices because these are non-pharmacological. So you don't have to take, and it doesn't go into your bloodstream or into your system. So you have an opportunity of reducing the seizure medication with the help of these devices. So this is a graph. I will not go into detail of this graph. This is comparing these three different modalities. The only thing I want to focus is that regarding the MRI of the brain. So with the vagal nerve stimulation, you can have an MRI of the brain, and it's MR conditional. You can have also with the DBS, but not with the responsive neurostimulation. What is the complication of this procedure? With vagal nerve stimulation, you can have infection, you can have hoarseness of the voice, you can have vocal cord paralysis, but these are rare side effects. With the deep brain stimulation, there's a risk of infection, misplaced leads, paresthesias, which is tingling or numbness. With responsive neurostimulation, there's a risk of infection and hemorrhage. So this is another interesting device, which is not FDA approved yet. So it's external trigeminal nerve stimulation. So the idea is that it stimulates the trigeminal nerve, which is a sensory nerve of the face. And the trials are still in progress, and the preliminary data showed promising results. So again, it's not FDA approved yet, so we are not using it at the moment. So I'll talk about the surgical options. And it's very important because, as I said, that 30% of the epilepsies are medically intractable. So every effort should be made to explore the surgical options versus devices, so as to have a better outcome for the patient. So there are several different types of surgery for treating patients with epilepsy, and patients who don't respond to the medication, dietary therapy, or any other therapy. A person's type of seizure and where they begin in the brain are the key to deciding what kind of surgery may help. So it's not very easy to just take out any surgical procedure and do it. So it depends on what kind of epilepsy they have, whether it's a focal, whether it's multifocal, means they have two focus of having seizures, and whether it's located in the important part of the brain, because you may not be able to resect it or remove it out. So there are the following types of surgical options we have, which is focal resection, lesionectomy, multiple subpial transaction, laser interstitial thermotherapy, anatomical or functional hemispherectomy and hemispherotomy, corpus callosotomy, and stereotactic radiosurgery. I'll talk a little bit about these procedures as well. So focal resection means that you remove the area of the brain which could be causing seizure. Say, for example, if someone has temporal lobe epilepsy and then the temporal lobe resection is performed. Sometimes this temporal lobe resection is very selective and they try to remove as minimal part of the temporal lobe as if possible. So it can be temporal lobe resection or extra temporal resection, which means they are outside temporal lobe, could be in frontal, parietal, or occipital head region, depending on the area of the brain involved. So focal resection means taking out the part of the brain which is causing seizures. So another technique is lesionectomy. Like you try to remove the lesion in the brain, which is responsible for causing seizures. Say, for example, these lesions could be FCD or focal cortical dysplasias. So these are abnormal collection of the neurons inside the cells, neurons inside the brain. So they can give you seizure. You try to resect or remove that area. And certain tumors, small tumors like glioma or DNETs, or they can also give you seizures. So you try to map out the area and you can remove that and do lesionectomy. There are certain conditions like vascular malformations, like arteriovenous malformation, cavernous malformation. So they can also give you seizures. So you try to remove that lesion from the brain. Of course, all of these kind of procedure require extensive workup in order to delineate, which part of the brain to remove and whether they can remove it or not, because you cannot take away the important part of the brain which is responsible for causing a lot of disability. So in that case, you will rather not go with the surgical option, and you can try devices like RNS. So there's another procedure which is known as multiple subpial transaction. So this is a technique which makes a small nicks on the surface of the brain. And the idea is to disconnect the fibers which could be causing the propagation of seizures. As we know that epilepsy is a network disease. So when the seizure starts, the neurons, they communicate to other neurons and cause propagation of seizures. So if we know that that's the case, then you try to do this procedure because sometimes, as I said earlier, it's not possible to resect every part of the brain. If someone is having a seizure from the part of the brain which is responsible for your speech, then you cannot take it out because then the patient will be left with a speech deficit. So rather you try to do minimally invasive, minimal techniques to cause any side effects. So in this technique, the epileptogenic zone is in dominant eloquent cortex, which means it's an important part of the brain that you cannot take it out. So it's a disconnection type of procedure to avoid resecting important structures. This is another popular technique known as laser interstitial thermotherapy. So it is done by putting a probe and reaching to the area of interest, and then the laser catheter is passed, and it causes heating or coagulation of the area which is responsible for causing seizures. It's done without opening the skull. So, a small hole is created inside the skull, and then the probe goes deep into the area of the interest where we think that the seizure could be coming from. So, so this is again a very popular technique these days, and it's being done very commonly in the comprehensive epilepsy centers. Then there's another technique which is known as anatomical or functional hemispherectomy and hemispherotomy. Sometimes one side of the brain is responsible for causing seizures. And despite treating with several different seizure medication, the patient unfortunately has a lot of seizures. So in that case, there's an option of doing functional hemispherectomy or hemispherotomy, taking part of that hemisphere out. So this is also one of the techniques that's sometimes done in the patient with Rasmussen encephalitis. And And so this is also an option for the curing or treating seizures. There's another technique called as corpus callosotomy. So if you can see in this diagram that we have two hemispheres, two parts of the brain, right and left. So they are connected to each other through this area known as corpus callosum, which connects the fibers between these two hemispheres. So sometimes what you do is that you disconnect those fibers and you can help improve the seizures, because sometimes the seizure start from one part of the brain and they rapidly spread to another hemisphere and cause more problems. If sometimes, it helps with the seizures severity and frequency. Then there's another technique known as stereotactic radiosurgery. So what happens is that the patient is put into this machine, and then there's a lot of first we have to know where the seizure is coming from. Then you put the patient in the machine, and then the gamma rays are emitted to the area of interest, and try to cure the area which is responsible for causing seizures. So of course, the candidate selection is very important. So, I mean, all the surgical options that I mentioned, whether it be devices or surgical options, patient has to undergo extensive testing, which includes getting an MRI of the brain, a high resolution MRI brain. It includes what we call as stereo EEG, where they put the electrodes inside the brain to monitor the brain activity, so as to pinpoint where the seizure could be coming from. And sometimes they need very fancy testing like a MEG scan or magnetic encephalogram. They also need sometimes what we call as PET MRI, or to look for the area of hypometabolism or decrease functioning. Sometimes they get what we call as SPECT, which is done by injecting when the patient is having a seizure. So the idea is that when the patient is having a seizure, the dye will get concentrated in the area of the interest. So the purpose of putting this slide is that it's not an easy way to surgery. The patient has to go through extensive testing and monitoring in order to decide what kind of surgical procedure the patient will need. Because with the brain, you cannot go wrong. It's the margin of error is very less in brain. So you're dealing with the brain, and so the margin of error is very low. So you have to investigate a lot, and then after doing all the investigation, you discuss the patient in the conference, and then you decide the treatment plan. So a brief talk about the COVID-19 and epilepsy. As I mentioned, one of my patients today was asking a lot of questions, very good question about COVID-19 and epilepsy. So I thought, this is a good platform to educate community a little bit about it as well. So what we know is that the available data suggests that having epilepsy does not increase the risk of getting COVID-19, and it does not increase the severity of COVID-19. There's no evidence that patients with epilepsy have a weakened immune system, except for certain kind of epilepsy like autoimmune epilepsies. Vaccinations are okay in patients with epilepsy, nor does it suggest that patient cannot take vaccine. Just a brief take-home message to limit the exposure to COVID-19, as we know that we are going through this unprecedented pandemic, and so we all have to defeat it, and everyone has to play our part in order to achieve our purpose. So, I mean, we should definitely wash our hands regularly with soap and water for 20 seconds. We should avoid touching your eyes, nose and mouth. Cover your cough or sneeze with a tissue, then throw the tissue in the trash. Keep at least 6 feet between you and others. Wear a mask when you leave the house. Stay home if you are sick, and call your healthcare provider first if you need an appointment. Clean and disinfect frequently. Touch objects and surfaces. So these are some of the basic measures that can be done to limit the spread of COVID-19. So the take-home message is that patient with seizures should be evaluated to determine whether patient has epilepsy or not. If diagnosed with epilepsy, it is of very utmost importance to know the type of epilepsy if possible. Sometimes it may not be possible to tell and may need a repeat extensive investigation. When medications fail, non-pharmacological options should be explored, which includes devices, surgery, etc. Stay safe and get vaccinated against COVID-19. So I want to share some patient resources. So Epilepsy Foundation website is great. There is a lot of information about epilepsy, its seizure types, what is the treatment options, whether it be medical, surgical, women with epilepsy, SUDEP, and COVID-19 epilepsy. There's a lot of information on this website. And they frequently organize events like Epilepsy Walk. Of course, due to this COVID-19 pandemic, it didn't happen this year. They have summer camps and all those community events so as to raise awareness about epilepsy. And so it's a good resource. Everyone should visit the Epilepsy Foundation website and you will get a tons of information about it. And whether it be about medication, surgical options, living with epilepsy, pregnancy and epilepsy. So there's a lot of information. Please check that out. Well, thank you. I really appreciate your time. If you have any question, I'll be more than happy to answer your questions.
Thank you very much, Dr. Bilal. I appreciate the way you take a difficult subject and make it easy to understand. I would invite everyone to unmute yourselves now if you would like to ask Dr. Bilal a question. Okay, if there are no questions, I'm going to put my email address in the chat box. Feel free to contact me if there's anything at all I can do or any questions you might have. Also, you can feel free to go to our website at any time. Put that there. And if there is nothing else, then Dr. Bilal, thank you very much. And thank you to all of our participants.
I had a quick question if you guys can hear me.
Sure.
This is David, by the way. I was sort of intrigued by these psychogenic seizures and how sometimes they show up in patients also with epilepsy. I was wondering, what the ratio is for cross correlation there. Can you have, if somebody has a psychogenic seizure, are they more likely than the normal to have epilepsy as well? Or is it not, are they not correlated with one another at all?
Well, that's a good question. As we know from the medical literature that, epileptic and non-epileptic seizure can coexist. And the different literature have shown that it's somewhere between 13 to 20%. They can also have epilepsy. Between 13 to 20% of the patient can have epileptic and non-epileptic seizures. Having non-epileptic seizures, I don't believe it increases your risk of having epilepsy. So, but we have seen, as you know, in our epilepsy unit, so we have seen a patient who have both epilepsy and non-epileptic seizure at the same time. So
yeah, she came to mind. Yeah, exactly.
And the study shows that 13 to 20% of the patient have both. So it's very important to, pay attention to each and every spell because you may be treating it wrong.
Right. All right, thank you.
Thank you for your question, David. Does anyone else have a question for Dr. Bilal? Okay, then thank you all. Once again, Dr. Bilal, thank you so much.
It's my pleasure. Thank you.
Thank you.
Good night.